All right. Thank you all for coming to my presentation, Lumbopelvic Pain and Pelvic Floor Dysfunction. We're just going to talk about the connection between the two. Yes. So I'm Lieutenant Ebony Jackson Clark. I work in Chinle, Arizona. I'm board certified clinical specialist in women's health PT, as well as a certified lymphedema therapist. My pronouns are she, they. So we're going to go over the table of contents. First, we're going to go over anatomy. Then we'll go over the connection between lumbopelvic pain and pelvic floor dysfunction. We'll briefly go over examination, some things to consider to assess treatment goals. We'll do 2 case studies, and then the presentation will end and we'll start our lab. So we're going to start with anatomy. Okay, so this list is really big. It's really just meant to demonstrate the sheer amount of structures that originate in the lumbopelvic area, the amount of structures that attach, connect, or just reside in this area. So I highlighted some bones, ligaments, and fascia that directly connect to the pelvic floor in green. And then in purple, I put the joints of the pelvis. So we'll go over, look at some pictures a little bit more in depth. Oh, next. Okay, so first we'll take a look at the bones. So the pelvis consists of the ilium, ischium, pubis, and coccyx. The pelvic girdle is responsible for transferring load to and from the upper and lower body, and it supports the weight of the body, serves as connection points for muscles, and protects the organs. So okay, so next we have some ligaments. The ones I'll just point out are the anal-coccygeal ligament, which is a median raft that goes from the coccyx to the anus. So the ilococcygeus, the pubococcygeus, and the coccyx attached to it, and we'll go over what those muscles are in a couple of slides. We have the sacrospinous ligament that attaches to the sacrum and the coccyx, and the ischial spine and covers the coccygeus. And then finally, we have the sacrotuberous ligament, that attaches to the sacrum and the iliac tuberosities. And the sacrotuberous ligament is posterior to and connects to the sacrotuberous ligament. So we have the thoracolumbar fascia, which attaches to the trapezius muscle, the latissimus dorsi, the gluteus maximus, transverse abdominis, internal obliques, and quadratus lumborum. And then we have the endopelvic fascia on the right, which is the fascia of the pelvis and the pelvic floor, and it's made of it has split into parietal and visceral fascia, and it connects to the pelvic viscera. So here's another big list just to show you the muscles that are in this area. In dark purple, I put the adductors. In light purple, I put the hip external rotators. And then in light green, I put the pelvic floor muscles. And we're going to go into those more in depth right now. Okay. So here we have a view of the transverse abdominis, the internal and external obliques, the rectus abdominis, the multifidi erector spinae, and the quadratus lumborum. And here are the external hip rotators and the gluteals, the iliopsoas and the adductors. And then next we have the pelvic floor. Its functions are organ support, it has sphincteric function, sexual function, core stability function, and circulation. So a little bit more in depth with the pelvic floor. Usually you'll see it being divided into 3 layers. So we have the first layer on the right, which is the ischial-cavernosus muscle, the bulbospongiosus muscle, superficial transverse perineal muscle, and the external anal sphincter. And then in the middle, we have the second layer, which is going to have more of the uretogenital muscles. So we have external urethrosphincter, deep transverse perineal muscle, and the perineal membrane. Then on the third and the deepest layer, we have the levator ani, coccygeus, obturator internus, and the tendinous arc of the levator ani, also called TALA. So now we'll talk a little bit about the nerves. In green are the nerves that innervate the pelvic floor, And then in purple are the nerves that innervate nearby structures or structures that may refer pain to the pelvic floor, pelvic region. Okay, so here are the genitofemoral, the iliohypogastric, and the ilioinguinal nerves. So the genitofemoral nerve can be compressed during open hernia surgery, can cause pain in the upper thigh region, anterior scrotal skin, mons pubis or labia majora. It also innervates the cremaster muscle of the testicles. The iliohypogastric nerve can become damaged or entrapped during abdominal surgery or trauma to the abdomen. It can cause weakening of the transverse abdominis and internal oblique muscles. It also innervates the proximal medial thigh skin, mons pubis, labia majora, root of the clitoris, anterior scrotum, and then the root of the penis. And then the iliohypogastric nerve can be damaged during also abdominal surgery or maybe during sports or pregnancy, and can cause burning in the suprapubic and inguinal areas. And it innervates the transverse abdominis, internal and external obliques, skin of the suprapubic area, and the posterolateral aspect of the gluteal region. So a closer look at the nerves here have the levator ani nerve, or the nerve to the levator ani. It's on the superior surface of the, it's on the superior surface of the pelvic floor. It comes from S2, you can see that middle picture, it comes from S2 to S4. It leaves through the greater sciatic foramen, going anterior to the piriformis muscle, and then it crosses posterior to the ischial spine and re-enters through the lesser sciatic foramen, and then goes between the sacro and the tuberous and the sacrospinous ligaments, and then it travels through the pudendal canal and reaches the perineum near the ischial tuberosity. So I brought up all those ligaments, muscles, nerves, bones, because they all interact and work together, all affect each other, and I'll be referring to them in the later slides. So we'll go on to the next part, which is the connection between lumbopelvic pain and pelvic floor dysfunction. So just a brief overview of some prevalence of some of the conditions. So low back pain has a 7.5% prevalence, affecting about 577 million people. It is the leading cause of disability worldwide. Then we have pelvic girdle pain. So split that into sacroiliac joint pain and symphysis pubis dysfunction. SI joint is going to have about 15 to 38% prevalence, and it accounts for about 13 to 40% of people with back pain. And then the pubic symphysis disorder or dysfunction is about 31.7% of low back pain in pregnant women. Then we have pelvic floor dysfunction. Depending on where you look, the prevalence is about 10 to 37% in cisgender women and 2 to 16% in cisgender men. Depending on the diagnosis as well. So pelvic floor dysfunction is a big umbrella term that includes a lot of different types of dysfunction. Okay, so first we'll talk about pelvic floor. So the pelvic floor works with the rest of the core to stabilize the trunk during movement. So these are all kind of summaries of all the research. I didn't want to overwhelm you with research. I just put the summaries instead. So the pelvic floor is part of the inner core. It works with the diaphragm, the transverse abdominis, internal oblique, the pelvic floor muscles, the diaphragm, and the multifidus. And it has been shown that with supine leg lift and standing arm lift, the pelvic floor muscles activate before limb movement occurs. The pelvic posture can affect pelvic pain and pelvic floor dysfunction. So lordotic anterior pelvic tilt posture is associated with chronic pelvic pain symptoms due to muscle imbalances created in the abdomen, back, hip, and pelvic floor. And certain posture changes such as rounded shoulders, thoracic hyperkyphosis, lumbar hypolordosis, knee varus, and foot pronation are associated with pelvic floor dysfunction, including urinary incontinence, fecal incontinence, pelvic organ prolapse, and chronic pelvic pain syndrome. So we often think of like posture affecting low back pain, but it also affects pelvic floor dysfunction. So posture can contribute to pelvic floor dysfunction. Again, so hypolordotic and kyphotic posture increases intra-abdominal pressure, which increases compression of the pelvic floor and increases pelvic malalignment. However, this can be decreased by maintaining neutral curves of the spine, which helps absorb intra-abdominal pressure before it reaches the pelvis. Then we have hypolordosis and posterior pelvic tilt can also lead to increased resting tone of the pelvic floor muscles. And we know that with habitual posture compensations can change activation patterns of muscle, and habitual increased pelvic floor muscle activation can lead to weakness and pelvic floor dysfunction. Okay, so muscle imbalance can contribute to low back and pelvic girdle pain. So the pelvic floor is one of the muscles that can contribute to that when imbalanced, what can contribute to low back pain. So low back pain can be caused by muscle imbalance, and I listed all these muscles. I just wanted you to know that pelvic floor is one of those muscles. It's kind of overlooked a lot of the time. And having an altered lumbopelvic stabilization strategy of the core muscles and the glute muscles has been found in patients with SI joint pain. So we're going to move on to low back. So the pelvic floor muscles help stabilize the trunk and the low back. Excuse me. Contraction of the abdominal and pelvic floor muscles increases stability of the trunk and lumbar spine. Pelvic floor stabilization exercises have been shown to improve low back pain and urinary incontinence. Pelvic floor muscles also help stabilize the pelvic girdle. So contraction of the pelvic floor muscles increases stiffness in the pelvic ring in females and causes counternutation of the sacrum in both sexes. And then contraction of the transverse abdominis and pelvic floor muscles reduce shear and increase stability of the SI joint. And the pelvic floor muscles, they create a medial force on the coxal bones and help stabilize the sacrum. And some pelvic pain may actually refer to the pubic symphysis area. Okay, so abdominal muscles, the connection with the pelvic floor and the abdominal muscles, they work together synergistically. So the core muscles contract to stabilize the trunk and lumbar spine, and the abdominal muscles and pelvic floor contract during increased intra-abdominal pressure to protect the organs. So abdominal muscle contraction occurs in response to pelvic floor muscle contraction. So in healthy subjects, the pelvic floor is pre-programmed to contract before the abdominal muscles. And sometimes pelvic pain may also refer to the lower abdomen. Okay, the psoas. So the psoas and the pelvic floor actually share anatomical as well as functional connections. So we know that reduced hip flexion is a contributing factor to low back pain, and that stretching of the iliopsoas has been shown to decrease pain and disability in patients with low back pain. The psoas is connected to the pelvic floor and the transverse abdominis, the diaphragm, and the internal obliques via its fascia. So the tightness of the iliopsoas can also lead to entrapment of the iliohypogastric nerve, which can lead to pain in the groin and the pubic symphysis and weakness in the transverse abdominis and the internal obliques. So it's the psoas, the diaphragm, transverse abdominis, and pelvic floor act as stabilizers for the trunk, and they all co-contract for trunk stabilization. And both the psoas and the pelvic floor can refer pain and tension to the groin and scrotum. So I'll move on to the gluteal muscles and hip rotation. So decreased hip strength and range of motion are associated with low back pain. Reduced gluteal muscle or gluteus maximus and gluteus medius muscle strength has been found in patients with low back pain. And reduced hip rotation range of motion is also common in patients with low back pain. So specifically the gluteal muscles, they have an anatomical and functional connection to the pelvic floor. The pelvic floor muscles and the gluteal muscles act synergistically during load transfer, and they both compress the SI joint with contraction. The hip external rotators also have an anatomical and functional connection with the pelvic floor. So the pelvic floor is connected to the hip external rotators via the obturator internus, the endopelvic fascia, and the TALA, and the urethra. And strengthening of the hip external rotators can actually improve both pelvic floor strength and urinary incontinence. So this is something to keep in mind if you're not a pelvic health practitioner and you happen to know that one of your patients is experiencing urinary incontinence, they may possibly benefit from strengthening of the hip external rotators. So the hip muscles in general, so multiple hip muscles and the pelvic floor work together for lumbopelvic stabilization and pelvic floor function. So hip dysfunction is common in patients with low back pain, and multi-directional hip exercises can decrease low back pain. And strengthening of the hip extensors, abductors, and adductors has been shown to improve urinary incontinence and sexual function via the pelvic floor. Okay, and now onto the pelvic floor muscles. The pelvic floor muscles do not work in isolation. The urogenital system and pelvic floor muscles have thoracic, lumbar, and sacral innervation. The pelvic floor muscle or pelvic floor pain can refer to the lower abdomen, inner thighs, groin, genitals, perineum, and or anus. And the pelvic floor muscle underactivity, overactivity, or incoordination can lead to pelvic floor dysfunction. So usually when people think of pelvic floor dysfunction, a lot of people think of hypotonic, so underactive muscles causing all the problems, which can be the case, but sometimes overactive or hypertonic muscles can be the issue, or sometimes it's not an issue of either. It's just an issue of coordinating and using the muscles correctly at the right time. So in summary, the pelvic floor muscles do not work in isolation. They make up a large part of the body's core, which is the foundation for all movement, balance, stability, and flexibility. And pelvic floor muscles, along with other abdominal and hip muscles, contribute to the stabilization of the trunk, lumbar spine, pelvic girdle, and hip. And I have, continuing, trunk and hip muscle imbalance, reduced hip range of motion and strength, and altered lumbopelvic stabilization can lead to low back pain, pelvic girdle pain, and pelvic floor dysfunction. So strengthening of the hip muscles can improve low back pain and pelvic floor dysfunction, and strengthening of the pelvic floor muscles can possibly improve low back pain as well as pelvic floor dysfunction. And some key points to take away from this are that the pelvic floor is a key lumbopelvic stabilizer, and pelvic floor dysfunction can be affected by poor posture and dysfunction of the lumbopelvic stabilizers, such as the hip flexors, extensors, and adductors, and reduced lower quarter flexibility, range of motion, strength, and load transfer deficits with pelvic movement are lumbopelvic deficits that contribute to regional biomechanical dysfunction and compensation that contributes to the pelvic floor dysfunction. So I'm going to go next. We're going to just talk about some things to consider briefly when assessing for lumbopelvic pain to consider with pelvic floor dysfunction. So when doing a lower quarter or lower quarter physical examination or just lumbopelvic examination, it's important to keep an eye on a couple of things, not just for lumbopelvic dysfunction, like I said, but also pelvic floor dysfunction, because some of these things can contribute to both. So posture, we talked about that in a couple of slides before. Spinal mobility would be due to the innervation of the urogenital system in the pelvic floor that I mentioned before, since it has thoracic, lumbar, and sacral innervation. Checking for a tissue tone and irritability of the adductors, SI joint, pubic symphysis, abductors, since we know how they all work synergistically. We have strength, range of motion, and flexibility, functional mobility, and any special tests that can help find deficits that may be contributing to low back or pelvic pain or load transferring. Okay, for the pelvic floor examination, things that we're looking for are diaphragmatic rib and pelvic floor mobility with breathing. Looking for hyper or hypotonicity of the pelvic floor, sensation, pain or tenderness of the muscles, reduced mobility of the pelvic floor activation, strength, endurance, and coordination, and the ability to isolate and relax the pelvic floor. So a couple of goals and outcomes for treatment. We have overall increase in global lumbopelvic muscle activation and strength to reduce local muscle compensation. And we can do that by correcting muscle imbalances due to or causing poor posture, improving axial and hip mobility, improving core and hip extensor, abductor, and external rotation strength. And when it comes to the pelvic floor, we want to make sure we're rehabbing overworked muscles and improving pelvic floor function by reducing muscle tone, increasing extensibility, and decreasing pain, as well as increasing muscle activation, range of motion, strength, endurance, and coordination. So now we'll move into the case studies. I have 2 listed here, and they're on your handouts if you have a handout. Got 2, Andra? Okay, so the first case study. A 38-year-old woman comes in for physical therapy with the diagnosis of pelvic pain. She reports that she has increased pain in her genitals and hip during menstruation, sexual intercourse, running, in times of increased stress. In standing, notice she has an increased lordotic and anterior pelvic tilt posture. She mentions that she has a history of low back pain and that her back hurts during her period after prolonged standing, walking, or housework. She points to her left PSIS. She has recently started running again after stopping due to the COVID-19 pandemic. So what structures would you all suspect are contributing to the patient's symptoms? Did you say S?
Iliopsoas.
Iliopsoas, okay. Any other? Same thing. What are some other, let's see, for the hip pain during running? What are some things that can? Abductors, okay, lordotic and anterior posture, anything that would be contributing to that? Decreased core control, good. Okay, anything else? Yeah, pelvic floor. Right, so yeah, pelvic floor, abdominal muscles possibly, maybe hamstrings or erector spinae for that posture, glute max, glute med, SI joints, and she did point to the PSIS. Okay, second question is, what might your examination look like? And then part 2 would be, what might you expect to find on examination? And we can kind of split this up with either lumbopelvic or pelvic floor. So maybe what are some things you would look at?
Range of motion of the back and the hips.
Range of motion of the back and the hips, good.
Be like an SIJ cluster.
SIJ cluster, good.
Strength of the hip musculature and possibly the core musculature.
Strength of the hip and core musculature, good.
Screening for hip pathology. Yeah.
Screening for hip pathology, yes. Okay.
Running gait.
Running gait, yes. Okay, awesome. Anything else? And pelvic floor. Good. Yeah. So posture might be palpating the SI joint or adductors or any muscles where she was pointing at where there was pain. Spinal mobility, assessing for tenderness, possible tenderness with PAs in the lumbar, spine, or sacral area. Soft tissue, tone, and irritability. So maybe piriformis, pelvic floor. We're going to be palpating for pelvic floor, irritability, testing the strength of the hips. So yeah, the glute max, the glute med, quads, etc. Range of motion, some special tests like we mentioned the SI joint cluster, Laslet's cluster. Maybe she pointed to her left PSIS, so that is a Fortin sign, which counts as a test for the SI joint. And maybe because of her posture, maybe the testing for modified Thomas or something like that. And then for pelvic floor, yes, for pelvic floor, we were testing for possible, what I would think of with her with that pain, especially during stress, would be hypertonicity in the pelvic floor. The hip pain also coinciding at this kind of the same time, I might think of the OI, the external hip rotator that's connected to the pelvic floor. I would be expecting maybe some reduced mobility of the pelvic floor as opposed to hypermobility. And I would check for pelvic floor activation. Maybe it'd be okay. Maybe it'd be not so great. Maybe some low endurance because I'm thinking like a non-relaxing pelvic floor. It's poor relaxation, poor contraction. So it's probably not going to move very well. Okay, next would be, okay, in your ortho examination, you find that the patient has MMT scores of 4+ out of 5 on glute max and 4 and 4- on glute med left and right, respectively. SI joint provocation tests were positive for 3 out of 5 or 3 out of 4. So right thigh thrust, right Gainslands, and right-sided pain on sacral thrust. There was no tenderness of the soft tissues around the hip, buttocks, or greater trochanter. Single leg stance, single leg squats, and normal squat all looked good with the exception of minimal knee valgus with single leg squats. PAs of the lumbar spine were normal and did not provoke pain. Your pelvic floor examination revealed hypertonicity of the levator ani and obturator internus, pain with palpation of the obturator internus, 4 to 5 levator ani strength, 75% about range of motion, good endurance, but poor ability to bear down of the pelvic floor. What are some treatment options you would consider?
Something to work on the hypertonicity of the LA and OI is some relaxation or inhibition techniques.
So, okay, some relaxation or inhibition techniques for the LA and OI.
There's hip weakness. You probably work on
Hip weakness, glute med. Okay, good. Any other ideas? I'll give you some time.
It's working on
General motor control of pelvic floor.
TA,
Okay, ability to activate the pelvic floor with TA.
ability to activate and relax.
Ability to activate and relax throughout the range. Okay, and then Lieutenant Williams says postural education. Perfect. Okay, so yes, some things that you all said. And yes, increasing the glute med strength, possibly since they do work together at the hips and the pelvic floor to help reduce OI and LA overactivity. So like we said, the pelvic floor also stabilizes the pelvis, the lumbopelvic complex. So if other muscles are slacking, other muscles will compensate, including the pelvic floor. Addressing the posture. So lordosis and anterior pelvic tilt by teaching correct glute and core activation and standing with activities, increasing that glute med in that single leg squat. Let's see, LA and OI strengthening or rehabbing, and maybe some manual muscle, not manual muscle, some manual therapy to the pelvic floor, as well as some strengthening, and then activation and relaxation training. Any specifics that you're thinking of in terms of exercises or anything? And we'll go over that more in the lab too, but just if anything pops up in your head.
I think when I start maybe like laying down, palpating pelvic floor, and then teaching her what that bearing down feels like.
Okay.
So,
Okay. So starting in supine and then starting with range of motion and bearing down of the pelvic floor. Okay, perfect. Okay. Next case study. Case study 2. Okay, so our second case is a 40-year-old man comes to physical therapy with a diagnosis of groin pain. He reports that the pain extends from his groin into right above his left testicle and into the front of his thigh. Sometimes feels like a pulling sensation. The pain has progressed from intermittent to constant over the past 2 months. He denies abdominal pain or any bowel or bladder changes. There was no method of injury or mechanism of injury. He has a history of low back pain and pain that radiates into his buttock and down his leg. He does construction and carpentry and complains that his groin and back pain are both worse with heavy work. Let's start with what structures you suspect are contributing to the patient's symptoms. Okay, so adductor and ruling out radiculopathy from the lumbar spine.
Hip flexors.
Hip flexors.
All the structures that you said refer to the area.
All the structure, yeah, all the structures that refer to that area. Correct. So yeah, so that's kind of what I was thinking. The lumbar spine, right? We have the iliohypogastric nerve that I mentioned before that comes from T12 to L1, and it innervates or provides sensation to the groin and the pubic symphysis and motor innervation to the transverse abdominis and internal obliques. And that one can be, that was the one that can be injured during surgery or any kind of trauma to the lower abdomen. So like, yeah, so maybe we would check the TA and possibly the pubic symphysis, since those are areas that it refers to. And then the hip flexors, so the psoas, because if that muscle is tight, it can also affect that nerve. And then the radiculopathy, so of the lumbar spine. And then also I would go ahead and check the inguinal canal, and because the spermatic cord runs through the inguinal canal, check for any like fascial tightness or just tightness in general. And then the pelvic floor, because the pelvic floor also refers pain to the genitals and sometimes to the anterior thigh as well. Okay, next. Okay, what would your examination look like? What do you expect to find on the examination? So more specifically, how would you check for those things? Lumbar range of motion, straight leg raise, palpation, muscle length, okay? Any other examination techniques or tests you might do? Maybe pelvic floor. So I would, yeah, or I guess from the beginning, it'd be looking at posture, right? Maybe he has some hyperlordosis going on. Palpating the inguinal canal, I said that before, this for the spermatic cord, the lower abdomen and the pubic symphysis, maybe even the piriformis, since she has that pain going down the buttock and the back of the leg. And just checking out the erector spinae since his posture is kind of poor. Spinal mobility, so basically just PAs, maybe that sacral thrust, tissue irritability, and all the inguinal canal, spermatic cord, pubic symphysis, piriformis, pelvic floor, manual muscle testing of the hips for sure, and the core, range of motion of the axial spine, and some special tests. I would probably maybe do some nerve tests, check for like slump or maybe femoral stretch, since it's in the front. Laslet's cluster for SI joint pain, since his pain that can sometimes also cause radiating, maybe not to the foot, but to the knee in the back. And then also maybe modified Thomas test to check his hip flexor mobility. And then I would probably also test his dynamic use of his abductors with like single leg stance or like just looking for Trendelenburg. And then for pelvic floor, this patient, I would suspect possibly hypertonicity as well. Probably going to have some painful spots, areas in the pelvic floor, maybe the elevator ani, maybe the obturator internus. I'm expecting to find like reduced mobility, um, maybe pora activation, and sometimes it's hard to distinguish weakness in the pelvic floor when there's hypertonicity, um, which is where I believe range of motion and mobility can help you come in. So a hypertonic or like a spasm muscle is going to sit up higher, but it's not going to move very well. So it might feel like, oh, that's a like pretty dense muscle, but it's not moving very well. Yeah, I'm expecting probably not, maybe non-relaxing, and maybe it'll be difficult to isolate that muscle as well. Okay, so what treatment options would you consider for this patient? Oh, let me read the. So in your examination, you find normal light touch sensation for L1 to S2. He has hypermobility along his, excuse me, that should say hypo. He has hypomobility along his entire thoracic and lumbar spine. He reports groin pain with the slump plus dorsiflexion test. Left glute med test is also painful, and then lumbar flexion aggravates the groin pain. The rest of the manual muscle testing is about 5 out of 5. You can't break him. He demonstrates bilateral knee valgus with single leg squat and bilateral uncompensated Trendelenburg with single leg stance. Faber reveals tightness in bilateral hips. Straight leg ham raise test is at about 60 degrees bilaterally. Modified Thomas test shows bilateral tight hip flexors with legs being about almost 5 inches from the table. In your pelvic floor examination, you find tenderness at the left adductor, the inguinal canal, spermatic cord, and externally at the bulbo and ischiocavernosus muscles. He is able to contract, relax, and bear down with his pelvic floor, and he's not valsalvating, and there's not really any other muscle contraction. So after this, what would you how would you start treating this patient? Maybe let's start with the spine, the hypomobility. Oh yeah, Lieutenant Williams says lots of stretching. Yes. Yes, he's pretty much tight everywhere, which is very common. So I would say starting with some like range of motion, getting that spine moving. Um, Maybe even just PAs or maybe some rotation, some flexion extension like cat cow, um, to start getting that spine moving. I'd say look at the hip flexors, the hamstrings, and the external rotators because he had the tightness with the Faber as well, and then the modified Thomas test. So yeah, stretching of those. I would also, going back to like kind of pelvic floor-ish, inguinal canal, spermatic cord, that is abdominal. So you could just test for restrictions there again, and then just do mobility, like literally hold and stretch in that area. Or the iliopsoas stretch where you're kind of in a standing lunge. If you just add a tilt, like a axial tilt to the left or the right, you can kind of mobilize that area as well because you're putting like a double stretch on it, pulling that area so they can kind of move. They can do a stretch or they can kind of move in and out of it so that like make it a mobilization instead of just a stretch. Hamstring stretch, let's see. And then sometimes like I do I do like the stretching, but sometimes I find that with, especially with pelvic floor, so I assume it's the same for other muscles. If a muscle is tight, yes, stretching is good, but sometimes it also needs to be strengthened. Because it's kind of almost like it's spasmed because it's weak. And so like I would do maybe gradual loading of that, gradual strengthening of that muscle to get it with lots of like range of motion initially, and then just like gentle strengthening to get it to where it doesn't need to feel like it's spasmed in order to be strong. Let's see. Glute med. Oh, since this person does construction, I would probably like with the hips, I would probably be looking at mobility of the hips since they're so tight and just the different positions they might have to get into for work. So making sure they have good mobility. He has good mobility in his hips as well. And then for pelvic floor, starting with maybe some manual muscle or not some manual therapy for relaxing, but also just range of motion and getting that pelvic floor moving and relaxing, and then addressing any other deficits from there. Okay, and I believe. Okay, so that's the end of the presentation part. Got about 10 or so minutes for questions. So are there any questions on any of the slides or case studies?
I have a question just in general.
Yes.
So
Mhm.
when I think of pelvic floor dysfunction, I feel like postpartum
Okay.
sedentary individuals, do you think is often ignored or underdiagnosed for the overactive physically population, like school athletes?
Oh, gotcha. Yes. So the question was, Clyde mostly thinks when he thinks of pelvic floor dysfunction, he thinks of either underactive or like pregnant population. Do I think that the active and sports population is underlooked,
Yep.
right, for pelvic floor? Yes. So the first thing that comes to my mind is that actual high activity athletes are actually at higher risk for urinary incontinence. And there are some, I guess, circles, I don't know what to call it, where it's just seen as normal to kind of like have urinary incontinence while exercising. Almost like something to be proud of. Because it's like, oh, you're working really hard, you peed on yourself. Um, yeah, so knowing that, I would say yes, that those people are probably a lot of times like with pelvic floor, and it depends on the population. So the population I saw before this, I rarely saw hypotonic pelvic floor. It was mostly hypertonic pelvic floor. And a lot of the people were active, but a lot of the people were stressed out. And so we know that people store like stress, like say in their traps or their shoulders. A lot of people, or their jaws, right? Their clinchers. Well, there's actually a connection between the TMJ and the pelvic floor in terms of like associations, I should say, that a lot of those same people are also clinchers down there as well, like butt clinchers and pelvic floor clinchers. So to answer your question, yes. And then for those people, like they're not necessarily like I don't like to use the word like, oh, you have a weak pelvic floor. Even though technically, like if you're looking at the length tension curve, a short or spasm muscle is just as weak as a not a long or I guess hypotonic muscle on the length tension curve. You need that right in the middle to generate like the strength that you need. So, but whenever I say weak, people are like, oh, my muscle is just like has no tone. It's just like completely useless and like won't contract. And it's like, actually, it's the opposite problem. So that's where I tell people, I'm like, yes, we're strengthening your pelvic floor, but we're strengthening it by lengthening it and bringing it to the middle of that length tension curve. So for those people, I would say, and a lot of times, like some people just like, there's the shame and the taboo about talking about it also. So I think that a lot of people can be overlooked and usually when I would get like my male patients, they were in so much pain because they just like they didn't know they could get help, and then they kind of like waited until it got really bad, and they're like, okay, am I dying? Let me go to the doctor. So maybe if we like talked about it more in the athletic um uh I don't know, community, maybe it wouldn't get that far and they wouldn't be as underlooked or overlooked. Yeah. Any other questions?
Wondering how like scoliosis might affect pelvic floor or like kind of how that asymmetry can like affect either muscles or
Okay. So the question was scoliosis and how it can affect the muscles of the pelvic bowl. So yeah, I would say so yeah, so scoliosis will definitely affect the muscles of like the whole lumbopelvic area. And so, which I guess we already know that. And so we're always trying to work on like getting balance back or like lengthening one side, shrinking the other side. And that's a good point that maybe the pelvic floor is underlooked because if there's like we've learned, if there's um, muscle imbalances in that area, the pelvic floor can be overworked and overactive. So I would say that that would be a good thing to add maybe to the toolbox. Like if you're having a patient with scoliosis and you're working on those muscle imbalances, maybe throw in some pelvic floor range of motion at least. Like you don't have to go like full out pelvic floor. This is your not pelvic floor patient, but maybe just like diaphragmatic breathing or just like pelvic floor contraction and relaxation or relaxation. And then considering both of them, I would probably throw that in there too. Yeah, that's actually a really good point. Any other questions? Yes.
People that present with like the whole combination of like SI joint pain, low back pain, possible pelvic floor dysfunction,
Mhm.
do you suggest starting at a certain area
Okay. So
rather than trying to tackle everything?
everything at once. Yeah. Okay. So the question was people with low back pain, SI joint pain, and pelvic floor dysfunction. Do you suggest starting with a specific area versus tackling it all at once? So my when I have patients like that who have the SI and the low back and the pelvic dysfunction, I'm really honing in on that lumbar spine and the global hip movers um, initially. And the reason for that is because we talked about the innervation of the pelvic floor and all that stuff and all those other muscles from the lumbar spine. But I feel like a lot of the times the lumbopelvic dysfunction is what is causing the pelvic floor dysfunction initially because it's what's causing the pelvic floor to be overworked. Like I'm not saying that it can't be this way, but I feel like usually it's lumbopelvic to pelvic floor versus pelvic floor to lumbopelvic. And so like I might start with pelvic floor, I might be like, okay, we're immediately going to start with diaphragmatic breathing to help with the range of motion and relaxation of the pelvic floor. But like, why is your pelvic floor spasm in the first place? Is it because it's doing more work than it needs to be doing? So I really like to start with, depending on their pain level of pain, range of motion. So we're going to do like cat cow and like rotation, like the basic motions of the spine. And then we're going to start with are they activating their glutes, like glute max specifically? Are they activating their core in general to kind of like brace and stabilize the entire trunk? And then maybe I'd like from there, like maybe do like, and also like the glute med, like something simple like supine, uh, hip abduction or something or hook line hip abduction, and like and just those. That's what 4 exercises. I've targeted all 3 of those because the glutes, right? The glutes are the glutes in the pelvic floor and the core, they stabilize the entire trunk. So the spine and the pelvic girdle. They compress the SI joint, um, or the SI joint, which a lot of the times I feel like the pain in that area is coming from like lack of force closure or correct or muscle activation. So like with just those 4 exercises, I already tackled like all 3 of the low back, SI joint, and the pelvic floor. And then I can kind of see like how they're responding to that. And then if I need to hone in more on like lumbar range of motion or hip strengthening or pelvic floor, I can go from there. Yeah.
Yes.
In your initial evaluation,
Mhm.
you asked about sleep posture
Yes.
and what would
Okay.
affect the person who sleeps on their stomach or somebody who has reflux that has to sleep sitting up.
So the
How
question
do
was,
those things affect?
okay, the question was how, during initial evaluation, do I ask about sleep posture? If someone has to sleep on their, like if someone has to sleep on their stomach or if they have to sleep up because of reflux, like how does that affect these issues? So I do, especially with my low back patient or low back pain and like pelvic girdle pain patients, I do ask how they're sleeping, so that we can modify how they're sleeping, not necessarily change their position, but like say they sleep on their back and they have back pain, I'm going to be suggesting,
Sleeping on their stomach.
oh, sorry. If they're sleeping on their stomach, I have this picture of all the different sleep postures and how you can place pillows to reduce the strain on your low back. So I don't necessarily tell someone like, don't sleep that way. I just show them a picture. Here's how we can make that more comfortable for your back. So if they have to sleep like reclined or they have to sleep on their stomach, I'll just kind of work with them on modifying it so it's not so much stress on that area, on their low back area. And I like I said, I have a picture, like this picture of all three sleeping postures, and I always print it out. I'm like, pick your, pick which one you want. And we'll really kind of talk about it and be like, do you have like extra pillows? If not, do you have extra blankets? Have you thought about buying a like a body pillow or something like that? Yeah, I just kind of walk them through them. Oh, let's see there. Oh, thank you, Lieutenant Williams, for coming. Any other questions? Oh, yeah, go for it.
When you're working on like range of motion, do you ever work on like actually bearing down, or is that usually like too much?
Um,
You're not trying to-
so yes, and like actual just like pushing down, like,
Yeah, or not
Mm.
like you're actually trying. to
or
push
just like making
down,
it go
but,
this
like-
direction.
But yeah,
Yes.
trying to like push down, like bear down like 50% or something.
Yes.
Not trying to actually
Not push down. Okay, so the question was, when working with pelvic floor, do I work on bearing down? So I usually, the first thing I am working on is relaxation, and I want that full relaxation, which I think is kind of like what you would be talking
Yeah,
about.
just to know if it's like, because I know
Mhm.
that you were talking about diaphragmatic breathing and how that's
Mhm.
just you can't get like full,
Oh,
full.
if you can't get that full relaxation.
Or like have them bear down.
I have in the past for people who are like just are not getting it, had them work on bearing down. And then I just make sure I tell them like we're not holding our breath. And then we're only doing this so that you can learn how to relax. So this is like a short-term practice that we're doing. Right, exactly. Yeah. So I definitely do work on the bearing down. And I usually tell people, I'm like, before we even learn to squeeze, you're gonna learn how to go the opposite direction. You're gonna learn how to relax because people are so eager to squeeze. And I'm like, that's not usually not your problem.
But
Mhm.
probably like most of the time diaphragmatic breathing works.
Most of the time it works. And then I actually, with diaphragmatic breathing, I will, we'll do the diaphragmatic breathing and then I'll move to like conscious like relaxation, if that makes sense. Yeah. Yeah. So I'll start with the diaphragmatic breathing just to get them like used to feeling their body moving that way. Cause a lot of times they're like not connected with that part of their body. And then from there I'll add the
Like this is when you're relaxing.
yes, exactly. This is when you're relaxing. Mhm.
Okay. And the whole time you're palpating.
Yes. Yes.
And for males, like when you're doing this for males, are they like laying on their side when you're
Mhm.
palpating? Or like what?
The question was for with males, what position are they in when I'm palpating? So if it's an external exam, I'll just have them lay on their back in hook line. If it's internal, I have them lay on their side. It's in side line. And then we can go over more of that too in our lab. Okay.
Just curious as to which way imaging may be helpful in identifying pelvic floor
Okay.
issues.
So the
Yeah.
the question was, in which ways is imaging helpful in identifying pelvic floor issues? So And when I think of like imaging for the pelvic floor, I'm thinking of like ultrasound is probably the most in terms of actual imaging and visualizing the pelvic floor. And it's actually really helpful. It's just not always accessible because it's kind of expensive to have a real-time ultrasound machine. But the reason I like that is because you can see you can see the pelvic floor, you can see it contracting, and you can also just see the bladder, and you can see whether it's elevating or depressing, I guess, like up and see its movement, and you can confirm whether the pelvic floor is doing the correct thing. I mean, you can do the same thing with your hands, but sometimes it's nice to have an option and that's not invasive. But yeah, you can have them squeeze and you see the pelvic floor thicken and lift and the bladder lift and vice versa for relaxing. The other imaging, and I actually have never had anyone who came to me just for pelvic floor have any imaging like available. Usually like back pain do, but usually not. Because sometimes a lot of times like if it's a nerve issue, it's like soft tissue restrictions or something like that. Any more questions? Mhm.
For like pregnant patients,
Mm-hmm.
with like pelvic floor activation, are you working a lot on strengthening? I talked to like one midwife and she was like, before I had my baby, she was like, are you concerned that if you work on your pelvic floor strength, that it's gonna like result in more tearing or like, and for me, intuitively, I was like, no.
Right.
Like if you have good like tone, but also are able to completely relax,
Mhm.
then the tissues are like healthy and able to move
Right.
throughout that whole range and it's gonna be fine. Same as
Mhm.
somebody who had like low tone or something like
Yeah.
that, I would expect.
Okay.
But do you ever get that question or whatever?
Okay. So question was, do I ever?
Like, I don't know, are you working a lot on strengthening
Okay.
still with people who are
Okay,
like,
we're pregnant.
before they're having their baby? And do
Right.
they ever ask you like, is this gonna make me tear more?
Okay.
Get really strong.
Do I work with strengthening on pregnant patients, and do they ever ask if strengthening will lead to like negative outcomes like tearing during childbirth? Strengthening definitely like 100% yes. And I don't think there's any correlations with strengthening and tearing in like the research, but there's so much correlations with strengthening with better birthing outcomes and like all the pelvic floor dysfunction afterwards. Um, and like I said, if we're doing strengthening of the pelvic floor, the first thing I do is the relaxation anyway. So, and I'm always trying to remind them, like, remember, do not do that next contraction until it is the first one has been completely relaxed. Yeah. Yeah. So yeah, because I think tearing has more to do with like positioning and the ability to relax versus whether the muscle is strong or not strong, I guess. Yeah.
Do you know if there's anything like with somebody who isn't able to relax?
Mhm.
If they do have more, I think that's probably not research.
Yeah, I'm not, so the question, is there any research showing that if a person can't relax, that there's more tearing? I'm not aware of that, but I would assume that it might lead to, it could, but also maybe even other issues like prolonged like deliver or pushing and stuff like that and delivery. Um, or I would think like if it's not flexible, the baby's gonna come out somehow. So there might be some tearing, or they might have to do a C-section if it's just not progressing with the
So like education to women or question whether or not they should be strengthened.
right.
Once you have good strengthening and relaxation.
Yes, good. Exactly.
Strong.
Exactly. Yes, yes. And I would even say, like, if they're kind of afraid of that word, strengthening, you'd be like, just make sure you have good range of motion. Go through the entire range of motion of the of the muscle. And like it's not, I mean, you don't necessarily have to wait or weight that muscle for it to get stronger anyway. So they're gonna be strengthening either way.
Yeah.
Yeah. Yeah. That's
Would your treatment be different for somebody who has a history of femoral hernias?
would the treatment be different for people with a history of inguinal hernia or femoral hernia? Not really, to be honest. I would just make sure that they do have that core activation and like the activation and what do you call it, the tightening of that areas. Because sometimes, like I guess if you had the hernia, there's that weakness in that abdominal wall. If they had the surgery, it should be fixed, but maybe they have residual weakness post-surgery. So I just want to make sure that they're able to activate so that they can manage the intra-abdominal pressure, because that's like where the issue is with hernias, is they can't manage it. If they can't manage the intra-abdominal pressure, then with their abdomen, then there's just like more pressure pushing out, right? And that weak area of weakness.
Because if you're tightening it, then you're pushing.
If you're tightening it, you're kind of like, it's like a corset almost. And then if you're tightening it, you're bringing it in. So like making sure they're not like valsalvating, which is where they push out. They would be belly button back towards spine, as opposed to pushing and making it hard, pushing it out and making it hard. And then by doing that, you're also protecting your organs. So, any more questions?
Use of SI belts, what do you think of that?
Yes, so the use of SI belts, they have been shown to work, especially in pregnant patients with SI pain. It's basically just mimicking, like I would obviously still work on lumbopelvic strengthening with them. It's just mimicking force closure. So if it helps them get through, like, because I mean, it's a temporary, I mean, I know it's 9 to 10 months, but it's a temporary condition. So I'm not going to be like, no, you can't do this or else you'll become weaker. But I would definitely encourage strengthening, because to me that's showing lumbopelvic weakness in the muscles and the force closure. Because well, I guess it's loss of form closure, right? From like the extra mobility, and they need their muscles to be stronger to add force closure. So that's just helping them. And I would tell them, like, if you work on this now, like your pain might not go away until you give birth, but you're strengthening your muscles and you're reducing the duration of your symptoms postpartum, because that has been exercise and lumbopelvic exercise, low back exercise has been shown during and before pregnancy, has been shown to reduce duration of symptoms postpartum. So like even if you don't get to your goal during pregnancy, you're still helping yourself out in the future by focusing on these the strengthening.
What kind of like frequency or dosage with use of the SI belt? And do they use it during exercises or no?
So frequency and dosage of use of SI belt and using it during exercise. I really leave it up to them. The exercise, I would encourage them not to, because I want them to be able to feel like, hey, am I tightening enough to feel a difference? Like, do I feel that my muscles are helping stabilize? Do I feel any reduction in pain when I'm doing this? Because I feel like that's a form of feedback, biofeedback. So I would encourage them to maybe use it like if you're going out to the mall or something like that, as opposed to just all the time. Like if they're one of those people that's just having like a really difficult pregnancy, then just do what you have to do to get through it. But in general, I would say like try to take it off and exercise and just use it when you really need it. Mhm. Okay, all right, so then I will end the recording and we can start the lab.